and stuff do we have there?
We are 4. We are still waiting for Hanifi.
Okay. So at some point, I will want some people to answer some questions. So I'll pick on you guys and you guys can decide who can talk because I can't really see who's all there. Okay, but so I think most of you know me. I'm Bernie Chodirker. I'm a medical geneticist. A lot of my practice is related to prenatal diagnosis. So what I'm going to talk about is what implications prenatal diagnosis has for neonatology and pediatrics. So after this session, I want you to be able to describe the prenatal screening for neural tube defects and the management of such cases. I want you to be able to describe the pediatric implications of SAW sign, identify the major indications for prenatal diagnosis, conditions that you can suspect based on maternal serum screening, and describe non-invasive prenatal testing. Okay, so the first case we're going to talk about is this one. 31-year-old in a first pregnancy, family and pregnancy history were unremarkable. Her maternal serum alpha fetoprotein at 16 weeks was 3.2 MOMs, or multiples of the median. Does everyone know what I mean by multiples of the median?
Is it like the increase in the level of the serum alpha fetoprotein, like compared to the average, or?
That's right. So AFP rises during pregnancy. So we have average values for each day of gestation, and we compare it to the average. We don't actually use the mean because you can have high values that distort it significantly. So everything is compared to the multiples of the median, and 2.5 or 2.3 in Manitoba is considered elevated. So this is an elevated MSAFP level. She went for a fetal assessment. Do you know what this slide is showing?
Yeah, the skull. Yeah, parietal diameter.
One person.
Okay.
It's showing the skull. Maybe they wanted to measure the biparietal diameter of the baby. I can't see there's any knockout fold.
Okay. Do you know what this indicates?
Actually, I don't know if it's an encephalocele in the back to the left side of the screen.
So this is actually referred to the lemon and the banana sign. So the indentation of the front part of the skull is called the lemon sign because the skull takes a lemon shape, and you can sort of see what looks like a banana in here in the posterior. So this is indicative of an Arnold-Chiari malformation, and that's highly suspicious for spina bifida. And in fact, on ultrasound, you can often see the spinal defect. So this is a baby with, or a fetus with spina bifida. So what risk factors are important in causing spina bifida?
Like the etiological wise, or just after birth or before?
Sorry, just a second. So I couldn't quite hear, but the important things are family history.
Yes, the folic acid deficiency.
And also certain medications, for example, valproic acid or other anti-epileptic medications.
Yeah.
What methods are available for diagnosing spina bifida in utero?
The ultrasound should be good tool and a simple one. I'm not sure about the fetal MRI in some period to check spina bifida and the brain clearly.
Okay, so yeah, so ultrasound is actually very good. Sometimes they will use an MRI to further delineate the lesion. In the past, we used to do an amniocentesis to check the AFP level, although we probably don't need to do that now that the ultrasounds are so good. But there are other reasons why we might do an amniocentesis. And as a screening test, the blood test is good. So we'll talk about some of that. We'll talk about prognosis, etc. So our spina bifida is an example of a neural tube defect, which also includes anencephaly and encephalocele. Overall, they occur in about 1 to 2 per 1,000 live births. About 5 to 10% would have a positive family history. So if we were to rely on the family history, we would miss the vast majority of cases.
Bernie,
So that's, yeah.
if the mom herself has spina bifida, is the rate still the same? Like, is
No.
it still,
That would be an increased risk, but again, you have to be careful what we're talking about. True spina bifida or multiple vertebral anomalies is a risk. Spina bifida occulta, which is just a radiologic diagnosis or whatever, is of no significance and it doesn't mean anything.
okay, thanks.
Okay, so we set up a screening program for maternal serum AFP, and it can pick up about 95% of cases of anencephaly, about 80% of cases of spina bifida. If it's a closed defect, we probably don't pick up any more than just by chance. Now, as I said, AFP is measured in multiples of the median, comparing it to the average. So when the baby doesn't have spina bifida, we see a normal distribution with the peak at 1 multiple of the median. If the baby has spina bifida, the AFP leaks out and we see higher levels. If it's anencephaly, the levels are even higher, and it looks like this. So if my goal was never to miss a case of spina bifida, where would I set my cutoff?
At 2.5 or 3.
Yeah, somewhere. Is that a good idea?
Maybe I will be a little bit, yeah, just there.
Yeah. So we don't do that because certainly there'd be so many false positives that we couldn't deal with it. Similarly, if I don't want to overcall any cases, I could set a cutoff at 5, but then I would miss the majority of cases. So most centers use a cutoff between 2 and 2.5. Manitoba uses 2.3. And with that, we will get some false positives, but pick up the majority of affected fetuses. In practice, the way it works, if you have a general population, let's say 80% detection rate, 4% false positive rate, 10,000 pregnancies, 10 have spina bifida, the rest don't. 80% detection rate means 8 are positive, 2 are negative. With 4% false positive rate, 400 positive. So the odds of being affected, or the positive predictive value, is 8 to 400 or 1 to 50. So in most cases, it's a false positive, but certainly it is a higher risk. Even if there's a family history of spina bifida, now the incidence of spina bifida may be higher, let's say 110,000. The risk may be 1 to 5. So a positive or an elevated MSAFP is suggestive, but not proof of a fetal defect. Now, guidelines have been published recently, or relatively recently, and it's sort of in some ways de-emphasized it. They say that we don't have to use AFP as a screening test in isolation anymore, unless you're unable to get a proper ultrasound, either because of maternal obesity or geographic factors. However, if you're doing it as part of a maternal serum screen, you can use it as a secondary thing. Okay, if we diagnose spina bifida in utero, how would you counsel onto the prognosis, and what information do you need?
It depends on the type and the location of the defect. And then also, okay, is it involving the brain or not? That is also another important factor for the prognosis.
Exactly. So now a small percentage of cases are due to a chromosome abnormality. So one of the things we would recommend or offer is an amniocentesis to make sure there is no evidence of a chromosome abnormality. In general, the IQ depends on the presence of hydrocephalus. Most have either normal to low normal IQs. Many will have specific learning disabilities. The ambulation depends on the level of the lesion, but many are non-ambulant by teens. There are other issues that occur, bowel issues, but most become socially continent, urologic issues, which have improved since intermittent catheterization. Most are capable of self-care, but do have difficulties with employment. people have, looked at, what is the outcome based on the level and whether they're treated or not. And certainly the higher the level, the worse the prognosis. Now, it's hard to use studies based on newborns to predict what's going to happen with a fetus. Part of the problem with these, most of the studies that have adequate follow-up are old studies. The outcome is only on the survivors. The anatomic level does not always equal the functional level. Hydrocephalus itself actually was a poor indicator of prognosis, and milder, we do expect it to be milder if it's skin defects. So people have looked at the prognosis based on identification in fetuses, and there's various studies that have been published. And again, the results, fetuses with lower lesion levels and smaller ventricular size were significantly more able to walk as infants. No infant with a thoracic lesion was ambulatory. All infants below L4 were ambulatory, and between L1 and L3, about half were ambulatory. Years ago, there was a study published on whether we should recommend a cesarean section or not. This study came out saying that yes, a C-section does improve things compared to the anatomic level. I actually thought it was a good study, but we've since reviewed that and other studies have come out, and basically there's no indication for doing a cesarean section. It doesn't really improve things, at least from the fetal perspective. Certainly a C-section can be done for maternal factors, but not necessarily recommended for fetal factors. Now, the management of spina bifida detected in utero has changed in the last few years. Previously, the only options we could talk about were termination of the pregnancy versus continuation of the pregnancy and postnatal care. Now there's information available on surgical treatment prenatally. It was initially done as a research study, but now we have referred patients to Toronto to have surgery done. Just from their website, the information says brain malformations were reversed by 1/3. The need for walking aids or a wheelchair was halved, and the need for brain shunts was reduced by a half. Now, that's the benefit of doing the surgery, but there certainly are risks of doing the surgery, including prematurity, the need for mom to have C-section, etc. But we have referred patients to Toronto. The inclusion criteria are that it's a singleton pregnancy, mom is over 35, the lesion is between T1 and S1, there is a Chiari malformation, and the patient needs to have a normal either karyotype or microarray. Exclusion criteria would be identified other anomalies or genetic syndromes, significant maternal disease, including or comorbidities, significant maternal obesity, insulin-dependent diabetes, abnormal placentation, abnormalities of the cervix, previous C-section or hysterotomy, or severe kyphosis. From a practical aspect, early referral is necessary to allow for comprehensive workup. They do the surgery between 23 and 25 weeks. We do have to have the normal karyotype or array prior to that. They'll do the fetal MRI and echo at sick kids. They have to remain in hospital for 1 week post-surgery, and after discharge, the patient are required to stay within 1 hour of Mount Sinai for the first 3 to 4 weeks after surgery, but then can be referred back to the local center. Now, other issues when we diagnose spina bifida prenatally, we talk about the grieving issues, especially if they're having a termination, reproductive counseling for future pregnancies, and advise them to take higher doses of folic acid. Any questions on this case or this topic?
Hi, Bernie, this is Ayman. So I'm asking if finding an elevated alpha-fetoprotein would be specific for neurotube defect.
No.
Or
So, like I say, most elevated AFP do not have a spina bifida. Many are just false positives, but high AFP can be associated with various other things. For example, gastroschisis or omphalocele, rare kidney conditions, fetal tumors can cause it. Wrong dates is certainly the most common cause that we see. An unexplained elevated AFP is also a risk factor for later pregnancy complications, including prematurity, intrauterine growth retardation, later fetal demise, etc. So AFP is a screening test, but again, most cases are not spina bifida.
Are the recommendations still the same for prophylactic folic acid? 0.4 and 4?
No, if the baby does have spina bifida or a neural tube defect unrelated to a chromosome abnormality, then they're recommended to go on higher doses of folic acid, 4 to 5 milligrams starting at least 3 months prior to conception, continue for 3 months after conception.
Thank you.
Okay. All right, let's go for this case.
Sorry, Anne has
Bernie.
her hands is up.
So Bernie, I
Oh,
have Bernie, this is Anne. I have
Hi.
I have a quick question. For the referral to Toronto, you said in your slide, I couldn't remember, is L4 to S1. Is that the lower one has a better outcome?
Yeah, it's because below this, the outcome is so good that probably prenatal surgery won't help. And above this, the prognosis is so bad that it's not worth doing it.
Got it. Okay, thank you.
One question is not directed to you, but overall, I was wondering, I just came, why we are not wearing latex gloves in this case? Why? Like always it says latex precautions. What is the reason? Just the audience, not directed to you.
I'm sorry, I couldn't catch that.
Why do they all have latex precautions? I think it's because they have a very high rate, of developing latex allergy. So, but I don't know why specifically, like, it's because they have a high rate of latex allergy, but I don't know why the spina bifida kids are particularly sensitive.
Yeah, that I don't know either.
Maybe because their spine is open?
Don't know. Or it could just be that they're going to have multiple surgeries, so you want to avoid that as a precaution.
Bernie, this is Deb. That's my understanding as well, is it's related to the number of surgeries they're likely to have over their lifetime.
Okay, fair enough. Okay, so you're asked to see a newborn whose amniocentesis was done in the pregnancy, showed a 45X, 46XY karyotype. We'll talk about why we do testing in pregnancy and what kind of testing is done. Well, what do you think of this case? What do you think the most likely outcome would be? Okay, so how many people think Turner syndrome is the most likely outcome?
I don't believe so. I think it's gonna be a normal male baby.
Okay, so let's go through this. Okay, so certainly the most common diagnostic test we do in pregnancy is an amniocentesis. You have to be at least 15 to 16 weeks to do it. We have done occasional ones later, although the risks may be higher, and it can be done later in pregnancy, although that may limit the options available. We can get a karyotype in 3 weeks. Nowadays, we're doing QF-PCR, which can give us a result in 5 days. A microarray can be done in about 3 weeks as well. We do make sure we discuss the procedure-related loss rate. Somewhere between 1 in 200 to 1 in 300 pregnancies, we estimate are lost. There is debate, and some people feel that that's actually a higher risk than we should be quoting. When we talk to them before the test, we talk about the possible results. In many cases, the results will be normal, which doesn't rule out all genetic conditions. If it is abnormal, then we will have the discussion with them whether to continue the pregnancy or stop the pregnancy. And we also warn them that there is a possibility of a failed test or an uncertain result, and we may or may not be able to offer more testing. Now, we do on some cases offer a diagnostic test called Corian-Villus sampling, taking a sample of the placenta rather than amniotic fluid. We don't do that in Winnipeg, but we do refer patients to Toronto or Calgary to have it done. It's done between 11 and 14 weeks in pregnancy, so it's in a situation primarily done because of a previous pregnancy or a family history. Occasionally, if we diagnose an anomaly earlier on. The risks of CVS are thought to be similar to amniocentesis, the advantages that it's done earlier. One of the theoretical risks with CVS is in CVS, we're taking a sample of the chorion, which almost always correlates with what the embryo is. But there are cases where these two are discordant. So there have been false positive reports based on CVS. I'm not aware that Down syndrome has been misidentified, but there have been a few trisomy 18s misidentified that way. Now, this is an example of a QF-PCR, and you can tell what probes we're using based on the name. So this is a probe for chromosome 21. This is a probe for chromosome 13, for chromosome 18. And so we have probes attached to 13, 18, 21, X and Y, and we get the relative dosage of those probes. Can people tell what the diagnosis is here? Well, if you look, like for chromosome 13, this probe is showing a 1-to-1 ratio. So that's suggestive of 2 copies. Here, there's only 1 peak for chromosome 13, and that may be that the 2 probes are identical on both chromosomes, but this part is suggestive of a normal ratio. For Down syndrome, for some of the probes, we're getting 3 copies, and some we're getting a 2-to-1 ratio. So that is suggestive of Down syndrome in that, and that we can do in about 3 to 5 days. A karyotype is actually where we're visualizing the chromosomes under the microscope. And in this case, it's the standard trisomy 21, the non-inherited form due to non-disjunction. A microarray is using DNA probes all along the chromosomes, and we're looking for differences based on the normal. So it's a much broader test. The main risk factor for Down syndrome is maternal age. As women get older, the risks increase. So that is our starting point for assessing their risk. Now, for a long time, we've known that if a baby has Down syndrome, the MSAFP tends to be lower on average. And so, for example, if it's 0.5, this curve is twice as high, meaning the likelihood ratio is 2.0. If a woman's age risk is 1 in 1,000 and she has an AFP of 0.5, the risk becomes 1 in 500. If it's 1.4, it becomes 1 in 2,000. So we can use that information to adjust her risk. The current standard of screening in Manitoba is what's called the quadruple test, where we measure AFP, which tends to be low in Down syndrome, HCG, which tends to be high, estrol, which tends to be low, and inhibin A tends to be high. We'll combine it with their maternal age, and some women, for example, women over 35, can also have a nuchal translucency at first trimester ultrasound of the fetal neck. Now, so the indications when we offer an amniocentesis, we used to offer it just on maternal age alone, and that's no longer done. We will offer it when there's a positive maternal serum screen. If the mothers or the parents has had a previous chromosome abnormality, or one of the parents is known to have a chromosome rearrangement or translocation. This is one of the guidelines that says if there's a family history of multiple trisomies, but to be honest, I've never offered it for that. And certainly we do a lot of amniocentesis because of an abnormal ultrasound, or because of they're at risk for disorders such as cystic fibrosis or something that needs DNA testing. Guidelines have been published on what to do, and there's various screening options that are available. Manitoba does a quadruple test. We certainly would like to do other tests, and there are various other options, including first and second trimester screening, but we're sort of stuck with doing the quadruple test, and a few women get a nuchal translucency. So those are the overall indications. So assuming this woman had an indication or amniocentesis for something like a positive maternal serum screen, and we found a 45X, a 46XY karyotype. Now, when you look at the postnatal cases, various reports have been published. So here's where many of them had Turner syndrome, gonadal dysgenesis, mixed gonadal dysgenesis, gonadoblastoma, or hypospadias. The problem with these reports, this is bias of ascertainment. These were studies done in a Turner syndrome clinic or a similar clinic where the babies were known to have a problem. So we can't rely on these reports to indicate the prognosis. And certainly there are case reports talking about short stature, delayed sexual development, ambiguous genitalia, cystic hygroma, etc. But people have looked at this from a prenatal point of view where amniocenteses were done for other reasons. In this study of the 92 cases, there were 39 terminations, 3 miscarriages, 2 stillbirths, 44 live births, 76 were examined after delivery. There was 1 male live born with a unilateral cystic hygroma, and that may just be coincidental. 1 male stillborn with spina bifida, again, probably not related. 74 males, of which 3 had hypospadias, and 1 female with clitoromegaly. Of the autopsies done, 2 had bilateral ovotestes and 1 had a precancerous testes. So overall, 95% have normal male genitalia, 27% may have abnormal gonadal histology. Not sure if there's a risk for gonadoblastoma. The degree of mosaicism, this should be, does not equal or does not predict the outcome, and postnatal cases may overrepresent abnormals. So in most cases, the prognosis would be normal male, and this is just a cultural artifact. Okay, questions on this?
Sorry. Go ahead.
Thank you for the, I'm Hamad, one of the fellows. Is it okay if you just go back 1 slide, if you don't mind? So out of the babies who were lost or did not make it, were these babies examined? Like, I mean.
Well, only 14 had autopsies. And again, I don't necessarily know why all the terminations were done. Some may have been done because of fear of the results at that time. Some may have been done for other factors.
Oh, okay, okay. Sorry, just one more question. Like it's 2 parts. One is, how precise is the standard ultrasound screen? And when does a mom be transferred to like a fetal assessment unit, like the one we have in Manitoba? That's more precise.
Well, as a general screen, if there's no other indication, so most women would be referred to a general ultrasound center. High-risk women, where there's a concern identified on the general screen, or because genetics refers them because of their family history or other factors, get seen by fetal assessment. So for the majority of lower risk cases, standard ultrasound is all that's recommended. Any concerns would be referred to fetal assessment. But certainly as a geneticist, if I see a woman who's taken teratogens or has a family history of something, I will refer them to fetal assessment.
Oh, thank you.
Okay, let's talk about this.
Sorry, Bernie. Limb anomalies was described as one complication more with microvillus sampling or the
Congenital limb abnormalities have been reported when we started doing CVS, but that was primarily when it was done under 11 weeks. So that's why we now don't do it at 9 weeks any longer.
Thank you.
Okay, so you're asked to see a newborn who was diagnosed prenatally with pyelectasis. What are the diagnostic considerations? What would you look for in history and physical? And what is the prognosis?
Unilateral or bilateral?
Sorry?
Is it unilateral or the bilateral?
Okay. Okay. What does that, why do you ask?
If it is a boy and the bilateral, etiologically could be different than the unilateral or
Okay.
the girl.
Okay. Okay, so that's one of the issues that we need to know. What else would you like to know?
I would consider oligohydramnios, maybe.
Okay. Okay. So with pyelectasis, that has traditionally been one of the what we call soft signs for Down syndrome or chromosome abnormalities. So a soft sign is described as a feature that's common in normal fetuses, but more common if the fetus has another condition such as Down syndrome or trisomy 18, etc. And there's various soft signs that have been described: echogenic cardiac focus, pyelectasis, so mild dilation of the renal pelvis. These are both risk factors for Down syndrome. Choroid plexus is a risk factor for trisomy 18. Echogenic bowel is a risk factor for Down syndrome and other things. And increased nuchal fold, which is a second trimester test, not first trimester translucency, is a risk factor for Down syndrome. And in the past, we used to adjust the risk quite aggressively and offer a lot of amniocentesis based on the findings of that. People have since reviewed the information, and we've probably been overemphasizing the risks for Down syndrome. So currently by itself, the only isolated risk factor that we adjust the risk for Down syndrome is an increased nuchal fold. The other one, if it's a single isolated finding, we don't increase the risk for Down syndrome. If there's multiple soft signs, we will, but the only risk factor by itself is an increased nuchal fold. So certainly one of the considerations that you would have to consider is, does the baby have features of Down syndrome? In most cases not, but it's something that you should consider. The prognosis depends on the degree of dilation, and the SOGC guidelines talk about a neonatal ultrasound should be recommended for piloctasis more than 5 millimeters and a 30-week fetal assessment if it's more than 10 millimeters. So certainly this is a risk factor for renal dysfunction, hydronephrosis, etc. And they do deserve normal or follow-up on that basis, but certainly on the mild levels, most of them do well, and most of them do not have Down syndrome. Okay, how about this case? What do people think about this?
Well, I don't.
Isn't this another soft sign?
Yeah, okay, so it's a soft sign, and it certainly is a risk factor for Down syndrome, at least in the older criteria. This was a case that I saw years ago. These two babies had cystic fibrosis. I actually looked after this case here, and he was probably one of the most severe cases of cystic fibrosis in Manitoba. He basically never left hospital and died at 4 years of age. Are these parents related to each other? Should I put in a double line? No, they have a cousin in common, but they're not actually related to each other. So I counseled cystic or echogenic bowel is known to be a risk factor for cystic fibrosis. Given this family history, I was suspicious that that's what was going on in this case. We did an amniocentesis and confirmed that the baby had cystic fibrosis. I talked about the variability in presentation, the improvement in treatment now that we have early diagnosis and treatment, but because of their experience with this case, they chose to terminate the pregnancy. They came to me afterwards and asked if their 2-year-old daughter, who was perfectly healthy, could have cystic fibrosis. I said, probably not, but it's easy enough for us to do a sweat chloride. And in fact, she did have cystic fibrosis. She was asymptomatic at 2. She started having some mild lung disease at 4, and as I understand, has done relatively well since then. So it certainly illustrates the variability in prognosis for cystic fibrosis. But echogenic bowel can be due to decreased swallowing or decreased peristalsis due to a bowel obstruction related to thickening of the meconium. Chromosome abnormalities, specifically Down syndrome, are most commonly identified, but it can be associated with cystic fibrosis, as I've said. Viral infections, CMV and toxoplasmosis can also have it, and occasionally it can be related with other anomalies as well. Now, when we diagnose it prenatally, one of the options is an amniocentesis. In many cases, couples will choose not to have any testing, just rely on newborn screening. Alternatively, what we can do is carrier testing of the parents. Our current carrier detection rate is about 90%. So if we test both parents and both parents are carriers, it doesn't prove that the fetus has it, but it makes us like 95% sure. If we test the fetus and the fetus has it, it's about then it's 100%. If we don't identify any mutations in the parents, it's really quite a low risk at that point. So we do have various options. But with all of these soft signs, I think it's important to you realize that they do cause anxiety. Most of the time, the outcome is normal, but some follow-up, whether it's to, check for Down syndrome or follow-up for cystic fibrosis or kidney obstruction is warranted. Okay, any questions on that case?
The genetic test versus sweet chloride test. So which one is the first one, and what is the value, and what is the both
Okay.
are test? Yeah.
So it depends on the situation. Certainly in the prenatal world, I don't have access to sweat chloride on the fetus. So we would do either carrier detection or genetic testing on the parents or an amniocentesis, depending on what the parents want. Once the baby is born, newborn screening would be the first test to do. If you have a strong suspicion of CF, then I would do genetic testing. The sweat chloride can be done later, especially if it's a negative test, but it usually takes a few weeks before the baby is big enough for a sweat chloride.
Okay, thank you.
Okay. What do people think of this case? So we have a woman who's going to be almost 35 on her due date. She was 16 weeks and a bit when tested. Her AFP was quite normal. Her HCG was low normal, but still normal. But there was no multiples or no estriol level detected. The Down syndrome risk based on these values was low, but we're dealing with an undetectable estriol level. This is the family history. Both of these people here had a skin condition looking like this, with chronic dry skin, what's called a form of ichthyosis, and this is one of them. So what do people think the inheritance pattern for this condition is?
This is okay.
Sorry?
I'm just thinking. It should be dominant, as well as I know, but in this one,
Well, it could be autosomal dominant, but anytime you see two males going through an unaffected female, X-linked is the most common. And in fact, this is a relatively common condition called X-linked ichthyosis or steroid sulfatase deficiency. And we pick up many cases because of a low estriol level. It occurs in about 1 in 6,000 males. They can have a deletion in this area, just involving the ichthyosis gene, but sometimes it can involve the surrounding gene causing other problems. It may be associated with delayed onset of labor, the chronic skin condition at birth to 4 months. There may be mild eye findings of no significance. Biochemically, we can test for it, and we can also do other tests for it as well. So this is a very common situation that we see. Here's another case where we had a relatively low estriol. AFP, estriol, and HCG were all low. When all of these three are low, that's certainly a concerning sign for trisomy 18. The Down syndrome risk became quite low, but the trisomy 18 risk became significantly higher. The fetal assessment showed a pericardial effusion, short femurs, and abnormal feet. What do people think the diagnosis is?
Bruxisoma disorder?
Sorry?
Zellweger?
I'm sorry.
Zellweger?
No, it's not.
Zellweger.
But certainly, based on this, I would have suspected trisomy 18. That would be the first thing. But in fact, the karyotype was normal. But then when the baby was born, this is what the baby looks like.
oh, this is oh,
So, okay, look at the feet. What do you notice on the feet?
This plastic nails.
Oh, there's 6.
this
Yeah.
is,
1, 2, 3, 4, 5, 6. And what about this?
Syndactyly, so Smith-Lemli-Opti syndrome.
Exactly. So this is Smith-Lemli-Opitz, has other anomalies, facial features, cleft palate, hand abnormalities, ambiguous genitalia. Smith-Lemli-Opitz is on the cholesterol pathway, which is on the pathway to producing estriol. So they are characterized by a low estriol level. We currently screen for Smith-Lemli-Opitz, although we're going to probably stop since we haven't found many cases over the years. But there's a broad differential diagnosis when we find a low estriol level. We can see it in anencephaly. Do people know why anencephaly gets it?
That was true.
Sorry?
No.
Well, in anencephaly, what happens is often the pituitary doesn't form, and if the pituitary doesn't form, the adrenals are not stimulated. You can get it in trisomy 18, Smith-Lemli-Opitz syndrome, X-linked ichthyosis, complicated X-linked ichthyosis with other features are all there. And then there's a whole long differential diagnosis that includes various other rare disorders of cholesterol metabolism, congenital adrenal hypoplasia, and a few other disorders. And that's one of the reasons why whenever I see a newborn with anomalies, I always ask the resident, what was the MSAFP? Was there, what was the estriol level? If it is a low estriol level, that may give me a clue to the diagnosis. Now, looking at the pattern of the triple screen or the maternal serum screen can give us a clue to diagnosis. So Down syndrome tends to be low AFP, high HCG, and high estriol, which is the same pattern we see if we've overestimated the gestation. She thinks she's 20 weeks, she's only 16 weeks. Underestimating the gestation gives us the opposite, so a high AFP, low HCG, and high estriol. And certainly we see lots of women for elevated AFP levels who've underestimated their gestation. I had one woman, well, how many weeks pregnant are you? Well, I'm 18 weeks. Are you feeling baby move? Yeah, it's been moving for about 3 months. Well, she was 30 weeks pregnant. Trisomy 18 is low across the board. Spina bifida has a high AFP, anencephaly a high AFP, and often a low estriol. Triploidy can have, or Turner syndrome can have non-specific findings, and X-linked ichthyosis and other conditions can have very low estriol levels. So again, this is something that we use, you know, in a screening sense, but also sometimes can help out in diagnosis. The last thing I want to talk about is the new technology called NIPT or NIPS, non-invasive prenatal testing or non-invasive prenatal screening based on cell-free fetal DNA. So most of this free DNA in the mom's circulation is mom's, but during the pregnancy, about 10% of the cell-free DNA is of fetal origin, and it can be detected at around the 5th week of pregnancy, although in practice, we wait till about 11 weeks to do the test. One of the advantages of this test is it's rapidly cleared after delivery. The older technology looking at fetal cells, sometimes the fetal cells could hang around for years, so you might be testing the previous pregnancy. But in this case, once the woman is no longer pregnancy, very quickly it disappears from her blood. Now, you can use it for single cell diagnosis. I've never arranged it, but the technology is there. And this is an example where the dad had Huntington's disease, and they were able to do a blood test on the mom to see if the fetus had Huntington's disease, which in this case, it did inherit the abnormal allele from dad. So that technology likely will be available in the future. Some centers are using it, but I've never been able to arrange it yet. Most of the time, NIPT is used for as a screening test for chromosome abnormalities. There's various technologies on the way it works, but one of the ways in which it's done is just by simple dosage. So in an oversimplification, let's compare the amount of DNA from chromosome 21 to 22, assuming they're equal. When the mom's not pregnant, the 2 chromosomes are equal. If the mom is pregnant with a baby without Down syndrome, then now there is more fetal DNA, but again, the 2 are equal. If the fetus has Down syndrome, now there's a little bit more chromosome 21 material, and that's one of the technologies that used to screen for Down syndrome. There are other ways of doing it, and that's an oversimplification. But it can be used as a screening test for Down syndrome and other chromosome abnormalities. Now, maternal serum screening based on the quad test picks up about 70% of cases of Down syndrome with a 5% false positive rate. So it's a reasonably good screening test, but far from perfect. For Down syndrome, according to this, the detection rate is 99.5% with a 1 in 1,000 false positive rate. So it's not a diagnostic test like amniocentesis, but it's a much better screening test. It's almost as good for trisomy 18, reasonably good for trisomy 13. It can screen for Down syndrome, it can screen for fetal sex, or XXY, XXX, XYY. The detection rate is, again, reasonably good, not necessarily as good. This is the standard test that's offered when it's being done. Women at no extra charge can choose to have screening for this, but then they also have to be counseled in advance. Do you want this information? Would it change your mind or just worry you to know that the baby has an extra X chromosome, in which case the prognosis is quite good. Some of the companies will also offer testing for microdeletions, or about 5 different microdeletions at an additional cost. Now, the Harmony test, which is the most common company I use, charges $500, and in most cases, the patients have to pay for it. We will offer to pay for it ourselves if the couple's had a child with Down syndrome or a few other indications. And during COVID, we've been able to cover it for women who've had a positive maternal serum screen. Now, one has to, so even though the detection rate for, let's say, Down syndrome is 99% with a 1 in 1,000 false positive rate, it's not a diagnostic test. And the predictive value depends on what the risk is going in. So, for example, if we had a young woman whose risk was 1 in 1,500, a positive predictive value would be about 42%. Negative predictive value is like 99.9994%. If her risk is higher based on MSS or age or whatever, the positive predictive value, if her a priori risk was 1 in 20, is now 98%. Negative predictive value, still quite good, but not quite as good. And this is why we certainly counsel women that this is not a diagnostic test. If they're going to act on the pregnancy, we really do recommend that they do an amniocentesis to confirm it before they decide on termination. Some women will decide to continue the pregnancy regardless and may choose not to have an amniocentesis. And in that case, postnatal testing may be indicated. For things like Down syndrome, you may just rely on the physical exam, depending on the risks going in. For something like XXX syndrome, where there's no physical features, you may have to do the test regardless of what the baby looks like. We don't encourage screening for the microdeletions in most cases. Part of the problem is that these are generally of lower frequency conditions. If we start screening for these, we are going to increase our false positive rate, which means more women will be having an amniocentesis, even though the fetus is less likely to be affected, again, given the low a priori risk. Now, I have done this on a few occasions for 22q deletion when the fetus has tetralogy of Fallot or something like that. So in that case, that may be warranted if the mother declines an amniocentesis. Again, it would have to be confirmed postnatally. But certainly that's something that we do need to talk about. Now, there's been a lot of discussion about, should this be the first line screen? And currently the test is not cheap enough that we can offer it as a first line screen. In Ontario, even without COVID, it's offered as a second screen for women who've had a positive maternal serum screen. We're trying to get that here in Manitoba, and I think it certainly makes sense. But certainly this is a change in technology that has dramatically altered the situation. There was a report from Iceland a few years ago where, because of this test, in 1 year, they had no babies born with Down syndrome. So it certainly has implications. Does it change how we value children with Down syndrome? Does it change the message that we're giving to parents and things like that? So while it's certainly a good technology, there certainly are lots of issues. Okay, questions or discussion about anything that we've talked about?
Thank you so much.
All right, any questions? Oh, Anne. You're muted.
After so many years, you still forget to unmute. So you're talking about the diagnosis test for trisomies. For example, in clinic, we have to do more and more the QF-PCR. And together, we also send a karyotype. As a clinician, if I already have the result of the PCR results, is a trisomy 21 whatsoever, should I wait for the karyotype, which you said take 4 weeks to tell the parents? Or?
No, so we consider the QF-PCR to be accurate, at least for what it's testing for. So obviously, a normal QF-PCR doesn't rule out something else. But if QF-PCR shows Down syndrome, yes, that does indicate Down syndrome. We ask for the karyotype primarily for genetic counseling purposes. 97% are due to an extra chromosome 21. Maternal age is the major risk factor. The risks in subsequent pregnancies slightly higher. But the 3% are due to a translocation, which has other implications for the mom and her relatives, etc. So we're doing the karyotype to rule out the translocation. It doesn't change anything. Now, occasionally you will get a result that's inconclusive. And one of the cases I heard about from Ontario is they saw a woman for a positive maternal serum screen. As part of the routine, they did the family history and noted that there was a family history of early onset Alzheimer's disease. So they did what I would have done in that situation, is saying, okay, you know what, let's deal with the positive MSS. We'll deal with the Alzheimer's disease at another appointment. They had an NIPT, and 2 of the 3 markers were, or one of the 3 markers was duplicated. So they weren't sure what it meant. It didn't look like full Down syndrome. They did the amniocentesis and confirmed that. But in fact, what happened was the duplication was on the gene for Alzheimer's disease. And this showed that the fetus and therefore the mother inherited the gene for early onset Alzheimer's disease. We know that one of the genes that causes Alzheimer's is on chromosome 21, because adults with Down syndrome do get early onset Alzheimer's disease. So she sort of had the test done before she received the proper counseling for that. So the test, bottom line, the QF-PCR should be accurate for the purposes of Down syndrome, as long as they say clear cut. If they say some vague thing saying one of the markers was not clear, we're not sure, that's different, but clear cut should be clear cut. We need the karyotype for other reasons.
Got it. Thank you so much.
You're welcome. Any other questions?
I just had a question. So we talked about the fetus. Sometimes the placenta itself can have mosaicism. How does that come into play?
So certainly that's being, and that may be one of the reasons why you get a false positive NIPT, because there's confined placental mosaicism. That false positive results for Down syndrome have been reported, or for trisomy 18 have been reported on CVS. They have been reported on, I'm not aware that Down syndrome is being reported on CVS. I'm not aware of false positives due to that being reported on amniocentesis. Although if we got a mosaic result on either CVS or amniocentesis, we would have to be cautious. So it's a theoretical reason why we may get a false positive, but to be honest, for Down syndrome, it really, I'm not sure it's actually happened.
Thank you so much. Thank you.
There, just as aside with mosaic, there have been cases of CVS showing trisomy 15. They do an amniocentesis and it's not normal copy numbers of chromosome 15, but later on the baby was born with Prader-Willi syndrome, because what happened is it started out as a trisomy, one was lost, and it ended up with uniparental disomy for chromosome 15. So, certainly mosaicism does play into our diagnostic routine if we detect it. Any other questions?
For the case that you just said, trisomy 15 one, you can only see that by karyotype to map it up, and you see the location, translocation.
Well, that's right. Yeah. It would have had to be done by either array or by karyotype. A QFBSR wouldn't normally detect trisomy 15, but a karyotype would, or an array.
Got it. Thank you.
Do you mind to elaborate more about microarray? How is it being done?
Okay. You mean indications or the technology?
Technology.
Okay, so basically you can think of microarray as a bunch of DNA probes starting at chromosome 1 from the top, here, all the way down, etc. So you have probes attached throughout the genome. You're then comparing it to the normal. So if, and there's a range. So if it's between 1.2 and 0.98 or whatever, that's considered the normal value for dosage for that specific area. But if you're getting 1.5 times what you expect at a specific area, that's considered that there's a trisomy. 0.5 would be a monosomy or whatever. And so they look at the dosage, and when you get, here, let me show. Okay, and share screen. Okay, so on this microarray, the various probes compared to the normal and expected were all consistent up until here. We're right at this spot. You see there was an increase in what you got. So, and this thing you mapped to chromosome 17p. So there's a duplication of chromosome 17p. Now, if it was Down syndrome, so then the pattern for chromosome 21 would be a duplication for the entire chromosome. Okay, does that make sense?
Yes, yeah.
Okay.
Thank you very much.
All right. Well, thank you guys. Chelsea, at some point we'll talk about doing that founder talk in March or so.
Chelsea is muted. She's on
Yeah.
service at SMB.
Yeah.
Okay.
She's probably busy. But thank you very
Okay.
much, Bernie.
Okay. Take care, guys.
Are you gonna come back in March, Bernie?
Well, I'll talk with Chelsea about it. I gave a talk on founder populations for palliative care. But I can modify it. There's certainly lots of founder mutations that we see in Manitoba, Mennonites, Aboriginals, Hutterites, where there's diseases that affect the newborn. And that would actually be something good to go over with you guys.
How about, my personal question, because over the years we saw trisomy 18, trisomy 13, they survive longer, especially the parents really want to get the cardiac surgery done. I would like to know the landscape in Canada, what's going on with those trisomy 18 and 13. In the old school, they all palliative, but in the new era, they all kind of survive longer.
So, I mean, there's certainly lots of debate now. I probably the best person to ask would be Rini Soni, because the main implications is the cardiac surgery, which my understanding is still not being done. In the, I know there are some long-term survivors. I've had one case of survived to 8 years of age, was very, very severely handicapped.
That's trisomy 18?
Yeah.
Oh, okay. Good. Thank you very much. Chelsea, Bertie was asking you about the next session.
Sorry, I was, Cherie was in my office. I'm on service. I'll send you some dates, Bernie.
Okay.
So for sure. Oh, did we lose everybody? Are we done? Sorry.
Yeah, almost done. Yeah.
I had actual work to do.
Okay. All right. Take care.
Okay.
Thank you.
Bye-bye.
Thanks, Bernie, and thanks, Chelsea.
See everybody at 2. Not Bernie, everybody else.
Yep.
I want to go do some work.
We need palliative care. We need palliative care for adults.
Yeah, the next talk is about palliative
Yeah.
care, right?
We need counseling.
Is it one of, let me check it out. Yeah, it's 2 p.m. You can come in here now. Come yesterday to, for
This
the,
country is run by politics.
Huh?
This country is run by politics.
yeah. I didn't see you yesterday. I didn't go for the lecture, I just went for the lab.
Oh, no, I have a squeaky voice, I still do. So you know what, I'm gonna freak everybody out.
So you just stay there.
I don't wanna be written up, you know?
You come back at me.
Yeah.
Go and rest. He did his SOE today.
Oh, man.
Really like the second spotter, like the first question is about AA gradient. Then chi-square and heterogeneity. What are they doing? Then an image for a baby. It's sebaceous navels. No, it's hemangioma.
Oh my God.
Hemangioma. I don't know what is it. Like, okay, what?
Imagine because they.
What are the
like,
complications and what are the
hemangioma.
syndromes about what? Just like I stopped writing. That's it, I don't know. It's not so clear, I don't know, it's sebaceous nevus or hemangioma.
Did they ask you about the treatment or that?
No, the syndromes, I mean, like, what's the syndromes that could be associated, what are the complications? What are name 2 tumors that can arise from it. What tumors can arise from hemangioma? Hemangiosarcoma and hemangioendothelioma, I don't know. I don't know. I just like, I'm not pretty sure if it's hemangioma, to discuss.
Were you alone? Were you alone or were you?
He was alone.
No, Dr. Ayman was
It's
on top of my head.
Oh, only you, no, the university.
No,
only-
SOE, not site, not the
SOE,
hospital.
okay.
You don't know the SOE that we do,
Dr.
the oral one,
Dr. Ayman.
that they'll be asking you about PDA, about all that. Yeah, I told them, like, it's not something, they just want you to read as a parent. It's local.
Name 6 things, name 8 things. What 8 things? I barely can count one.
Oh my God.
That, all the questions is just, no, I can count 8 things, count retinopathy of prematurity, yeah. What retinopathy?
It's local though. I thought you had.
No, I'm not so concerned because I know I was not reading well preparing for an exam. Even the seat, I mean, like, it's gonna be by 4 next fall.
Besides,
Yeah, not the
No,
side, I'm not registered already
side
for
is
the
next week,
side.
right? Sorry, next year. February next
I'm
year.
not registered yet for the side exam.
You have to register.
I'm asking Chris, it should be Dr. Ayman who was the one who was,
Yeah, they have to like confirm you first because you can't register on your
I
own.
cannot register, from last year.
Yeah.
I told Dr. Ganesh initially after.
Oh, okay.
He
I
did
thought
not-
you did last day.
Sorry?
You did site last
No.
year. Ah.
I did not do it last year.
I'm
This
so
year-
happy I'm on this year, like no side, no nothing, like class me,
For
like
free.
like borderline pass for that side that I did to Idama. More like borderline pass, like crazy, you're doing clinical rotation and you're preparing for science, you know. You just go and do, the only thing I enjoy about it is like being computerized, computer-based exam. You
Yeah.
don't have to be talking to anybody.
Exactly.
Just pick whatever you want to pick.
I
and
thought
pick.
today OSCE initially that it's just okay, they will bring me a mannequin and they will.
No.
No, it's oral, oh my
It's
God.
structured oral exam, they will
Yeah.
asking you, they will paint clinical scenario, what is
We
this,
had
what are the
pulmonary
that
hypertension.
PPH from PPG. It's not even straightforward PPH from like acute one, it's more like a baby with PPG now, because
The
of
development.
PPH, how you manage it.
For me, retinopathy of prematurity.
I
so
remember what's the other one? The metabolism one, hypermolemia.
I don't know.
Danish, like.
Once in a while, we need to read these pediatrics. been a while.
Yeah,
It's a bit almost stopped.
Actually, when you said it,
Oh my God.
actually, I've seen like one baby like that here. Initially, they thought was trisomy 18. Eventually, it was Smith learning of it. It
Really?
didn't come to me. Then when you said that,
Third dose
you
and
see it before, like the post, like genetics when they come and you read their notes. After trisomy 18, the next thing is Smith learning of it, like you might be the differential.
second, third dose and actually is first, but I mean, like, you know, yeah, really, we have to review the pediatrics, like, we're not so good with pediatrics.
Yeah, we have to reread it. It's something, especially genetics, is like the part of like last thing before the
Yeah,
exam.
because most of the time,
Just remember the
they
three
don't stay
stages.
long on our ward, right? They are the preliminary stage of investigation, then they go to pediatrics.
Like for me, when I study genetics, okay, Down syndrome is a high yield.
Yeah,
Or, you know, trisomy 18, okay, maybe high yield. Turner, okay, high yield. But the rest of it, you know, so what if I miss a case of Smith Clemens?
I don't know how they do it, like this they call them geneticist or something.
Geneticist.
They must be like genius, like it's a boring.
You know what they do?
They are more.
You know what they do?
Just
What
like
do
this.
they do?
Yeah,
Oh.
there's an application.
Send that to me, plus big nose.
Because I usually think how do they
That was
survive,
from
because
last time,
more like
yeah.
a
Just like
boring,
it's kind of algorithmic.
boring, like a more boring profession, boring specialty, like how do you cope? Genetics and metabolics.
Yeah.
Metabolics too, they should have an upright, I think they have.
Metabolic, I think it depends on the person. Like if you're into it, I think it'd be really fun
Oh,
to diagnose and how to treat and the enzymes. For me, I'm not.
yeah, I like the other, the man that talked to us.
Aziz,
Yeah,
Aziz
it's good,
Mahan.
it's good.
He's into what he
Yeah,
really
you know,
likes it.
he will give you quicker scenarios, back it up with, was really interesting for the first time when I listened to Meta. It's a boring, if you get somebody that is boring, you will enjoy it at all,
Going up.
All right, see you at 2.
Yeah, get a coffee.
Where do you want to go? You want to go upstairs?
Maybe the more people get a coffee.
We can walk down together. I have to, and what's going on? Like, I said, what is going on? You said you wanted to tell me something.
I was shut up.
You got.
I was shut up
Oh.
because you still need approvals and stuff. So the problem is, once you get the letter.
But I want you to put me through because I can't do, I
It's
don't
only
know.
valid for 6 months.
Oh.
So it's not, that's why I kind of backed off.
Okay, so it's better. not to waste your
didn't-
money until they have
Yeah, I
to-
didn't want to depress you,
No, I'm not depressed.
but
I'm not-
I think
you know
again,
what?
I didn't want to, I felt bad for dragging you into
No,
this.
no, no,
It's like
that's
I gave
fine.
you false hope,
No, that's,
but I'll still try and see if there's anything that shouldn't have, I'll let you know.
that's fine. That's okay. I understand because like, they have some tricky question and I don't want to fall into their pit again, when we were doing the residency thing, I think they screened us out because we are doing fellowship. They didn't even consider us because we are in fellowship program.
For me,
Like the other girl from Nigeria that got it, like I told you, she was not into fellowship, she was doing clinical assistant. And clinical assistant is not recognized as you being in training. Do you know what I'm saying? So she's very lucky.
no, the other thing is, Ottawa, they needed all the letters of recommendation not earlier than 2021. Which means they should have happened within the 3 months prior to Carm's opening.
Oh.
My recommendation, one of them was 2020.
Okay.
It was in December. So if they waited 2 weeks, it would have been 2021, and they would have actually considered it.
But like the one I had was, I think nobody's recording anything, the very next, okay? The one I had was just last year. I can still use it this year, right?
It depends on the criteria. Ottawa, we're very precise, we're very.
I know.
So maybe each year they just want, because it's a way of screening for them. They get so many applications, they don't know what to look through. They're like, okay, let's just do this, do that. And the other weird exam is the personality exam.
Oh, which,
I forgot what it's called. Casper.
Casper.
That's a weird exam, I don't know. But
That is
how,
crazy.
how are you grading people on that? But only if you're true sociopath,
Mhm.
then you'll do good. Because you know how to avoid weird situations. If you're a normal person, most likely you won't do as well.
Anyway, I went to Ema. I don't know,
You know what? Let's log out.
you want coffee, right? You can.
Yeah, let's go,
I
let's go,
can
yeah,
just
let's-
escort you down.
Let's go to coffee.
Uh,